Today I'm going to discuss regarding this topic which we had presented in Criticare 2026 in Chennai, and this was part of the ISCCM and Clinical Infectious Diseases Society Synergy session. So I'm going to discuss regarding this Enterococcal Bacteremia, a practical clinical approach. And like this picture of this chameleon who is camouflaging, Enterococcus bacteremia can also have different clinical manifestations, and this is something which I'm going to discuss today. I'm Dr. Neha Gupta, founder of NG Swastha Infectious Diseases Clinic in Gurugram, and I'm currently attached with Fortis Memorial Research Institute. So why are we discussing regarding enterococcal bacteremia? This is because Enterococcus is one of the prominent causes of the nosocomial infections. In fact, this is the data of the positive blood cultures of close to 600 isolates. And as we can see, among the positive blood cultures, Enterococcus is 6% of the total positive blood cultures, which is in fact the top 5 blood culture isolates. So in the West, Enterococcus is responsible and is probably second or third cause of the positive blood cultures. In India, we do have Coagulase negative Staphylococci, Klebsiella pneumoniae, as well as E. coli and Candida as the top 4. But Enterococcus at 6% is in fact higher than Pseudomonas aeruginosa, Acinetobacter baumannii, and even higher than Staphylococcus aureus. So enterococcus is a problem because it survives on the hands, gloves, gowns, and can disseminate in the hospital environment. It can acquire resistance. It is intrinsically resistant, but can also acquire the antibiotic resistance, and particularly this we see with the VRE, which becomes particularly very challenging to treat, especially in the ICU patients. So Enterococcus is a pathogen. It's basically a bacteria which lives very peacefully in the gastrointestinal tract. However, it has the potential to transform from a commensal to a pathogen. And this happens when there is a disturbance in the gut microbiota. When a patient in the ICU or even outside in the community receives antibiotics which eradicate the gram-negative bacilli, the antibiotics which are excreted in the bile, but the ones which have no activity against Enterococcus, this results in an unchecked growth of the enterococci. Now, this is also promoted by an increase in the stomach pH by use of the proton pump inhibitors, which is one of the strategies for reducing the aspiration pneumonitis in ICU patients. This allows the growth of enterococci, and then subsequently this enterococci translocates across the GI tract and results in bloodstream infection. And this is particularly much more important in patients who are elderly in the ICU, patients with comorbidities like renal failure, chronic kidney disease, chronic liver disease patients, immunocompromised patients, patients on steroids. They are the ones who are at a higher risk for Enterococcus infections, particularly if they have received antibiotics which are not eradicating the enterococci. So in clinical practice, the Enterococcus species which are isolated from the human infections are many. Out of these, the most common one is the Enterococcus faecalis, Faecium, Gallinarum, and the Cassili flavus species. And today I'm going to discuss related to how do we suspect Enterococcus bacteremia early, how should we diagnose, and then what is the management of enterococcal bacteremia. So let's take up the first one, which is regarding the clinical suspicion. This is a patient who is a diabetic, has presented with an acute right-sided MCA infarct and has developed a left-sided hemiplegia. He was admitted under the neurosurgery in the ICU, and then subsequently, as a part of the pre-operative evaluation, a 2D echo was done. Subsequently, post-surgery, this patient was put on meropenem as well as vancomycin, and on day 3, on these broad-spectrum antibiotics, this patient developed leukocytosis. The counts went up till 25,000, and that's when the blood cultures were also positive for this Enterococcus faecalis, as we can see here, where the turnaround time, it grew within 37 hours. So at this point in infectious diseases, reference was sought because the patient was having leukocytosis on the meropenem and vancomycin. So this also brings us to the discussion that when should we suspect enterococci, and which are the patients who are likely to develop enterococci. For example, this patient has presented with a stroke and is having blood culture positive with Enterococcus faecalis. So we have to divide Enterococcus and basically the patients as patient who is coming from the community and patients who are in the hospital. So the risk is higher in elderly patients, patients who have undergone genitourinary procedures like a cystoscopy or TURP, a transrectal biopsy, a lady who has undergone a hysteroscopy or a hysterectomy, subsequently a patient who is having some bone infections, and if there is there is some intra-abdominal infection which and a source which is not properly addressed, then that can result in bacteremia. In the hospital, it's usually in a patient who is in the ICU and is on a broad spectrum antibiotic like meropenem, subsequently has a new onset fever. So the possibility would be a CRGNB, Enterococca, and Candida. So it's a genitourinary procedure like which has been done like a catheterization. These are the most common causes or risk factors for enterococcal bacteremia in the hospitalized patients. Patients who are on steroids, immunocompromised patients, here again, there is also imbalance in the gut microbiota, and there can be translocation of the enterococci from the gut into the bloodstream, resulting in fever and sepsis-like symptoms. So any patient who's presenting with fever, with sepsis, Enterococcus bacteremia should also be considered besides the gram-negative bacilli as well as Staph aureus. So the various syndromes with which the enterococci can present are the invasive syndromes like the bacteremia. It can also present with endocarditis, intra-abdominal infections, and osteomyelitis, bone infections, diabetic foot, which can get infected with the enterococci. A person who has undergone a CSF shunt can have Enterococcus as the causative agent, and even in neonatal infections, late onset infections can be related to the enterococci. How do we diagnose it? So the diagnosis is usually on the basis of cultures, and for this the appropriate sample has to be sent. For diagnosing bacteremia, it's the right amount of the blood cultures, and usually 2 sets, which is 4 bottles, should increase the sensitivity. If we can send even 3 sets, that will be better. Now, definitely this is very important, but when suppose before having the proper report of ID and DST, which is usually available 48 hours or 72 hours later, is it possible for us clinicians to predict that this could be Enterococcus? So when the lab tells us that there is a blood culture which is growing a gram-positive cocci, usually our mind goes to that it could be Staphylococcus aureus or Coagulase negative Staphylococcus. But besides these two, there are other possibilities which includes streptococci like the VGS, nutritionally variant streptococci. We have strep pneumoniae, Streptococcus galolyticus, Micrococcus leuconostoc, and Enterococci. So GPC, all these should be considered. Now we can request our microbiology lab to tell us whether they are seeing GPC in clusters or they are seeing GPC in chains. So if it's GPC in clusters, then it's likely to be Staph aureus or cons. Whereas if it is GPC in chains, especially in the short chains, then it is likely to be Enterococci. Subsequently, it is then 24 hours later, we are going to get the proper drug susceptibility like this, where we will have the susceptibility to the various antibiotics. And of course, The other thing which can be performed is if there's a blood culture positive, a BCID panel or a MALDI-TOF can be also done, which will help us in isolation um, of the of the species early. Now, another important point is related to the drug susceptibility. That is, usually we have the drug susceptibility which is available as per the automated Vitex systems, but there are certain antibiotics which are not available in the cards which are used for checking the DST of the Enterococcus, and that's when additional antibiotic susceptibility should be sought out for drugs like Daptomycin, Minocycline, Tigecycline, Fosfomycin, and also now the levonidifloxacin that can also should be asked for if there is limited treatment option. Now let's come to the management. So in this patient who is presented with a right-sided Hemp-C infarct and is having this positive blood culture from the Enterococcus faecalis, Vanc is susceptible, what should we do? Continue with meropenem and vancomycin? Continue with vancomycin, but escalate to polymyxin B or ceftazidime avibactam because there is leukocytosis on already meropenem. Discontinue meropenem and add gentamicin to vancomycin. Give ampicillin with gentamicin. Give ampicillin with gentamicin. Now this brings us to the discussion of the antibiotics which should be used for treating Enterococcus. Now Enterococcus is a gram-positive facultative anaerobe. It is intrinsically resistant to many antibiotics, which includes third-generation cephalosporins, meropenem, clindamycin, TMP mix, as well as the fluoroquinolones. The antibiotic class which works the best for Enterococcus are the penicillins, especially the aminopenicillins. The ampicillin is the drug of choice, and ampicillin binds to the PPP4 and 5 and results in defective cell wall synthesis. It does not inhibit completely the cell wall synthesis, but results in defective cell wall synthesis. And even among the enterococci, there is a relative penicillin resistance. So, a higher dose of ampicillin is needed for treating the enterococcal infections. Now, if because for bacteremia in a patient who is not immunocompromised, even monotherapy is sufficient. But if the patient is suspected to have infections related to heart valve, that is infective endocarditis, meningitis, a Lyme, a neutropenic patient, then a CIDL therapy for Enterococcus is needed, and we must combine ampicillin with gentamicin, that is the aminoglycosides. As Enterococcus are facultative anaerobes, aminoglycosides, which require oxygen to go across the cell membrane, already have a limited penetration. So there is a low level aminoglycoside resistance already present among the enterococci. That is why the aminoglycoside susceptibility has to be checked in presence of higher concentration of the gentamicin at 2000 mg per liter and a high concentration of streptomycin at 500 mg per liter. At this, if the Enterococcus isolate is susceptible, so if this is a non-HL, if there is no high-level aminoglycoside resistance detected, then we can use ampicillin along with gentamicin, which will have the CIDL activity, because ampicillin will bind to the essential penicillin binding proteins 4 and 5 and result in defective cell wall synthesis, through which the aminoglycosides can penetrate and inhibit the 30S ribosomal unit, and this will inhibit the protein synthesis. So this will result in the cell lysis and will have CIDL activity. And here the aminoglycosides have to be given in 8-hourly dosing and not as a single dosing. Aminopenicillins alone will be static for the enterococci. Now, if suppose there is a alteration in the or a mutation in the PPP penicillin binding protein, so it's resistant to the beta lactams, ampicillin, or there's a beta lactam producing strain that will confer resistance to ampicillin. When there is ampicillin resistance because of the alteration in the PPP4 and 5, then the treatment option is vancomycin. Vancomycin can be, what it does is basically it binds to the initial precursor of the cell wall synthesis, binds to the DLR, and inhibits the cell wall synthesis, but it is again static for enterococci. It's not a cidal drug. If there is a change, mutation in the DLR to DLR-DLAC, that will confer resistance to vancomycin, and the other treatment option would be daptomycin. Daptomycin results in depolarization of the cell membrane, does not result in any cell wall lysis, and it has a very rapid cidal activity. Cell death occurs without cell lysis. However, the limitation is that the dose required for treating enterococcal infections is in fact higher what we use for the Staph aureus, and a higher dose, especially of 8 to 12 milligrams per kg, is needed for the enterococcal infections. If daptomycin the use is limited either because of the cost or because of the site of action, like for brain infections, the other treatment options can be linezolid, minocycline, tigecycline, and even fosfomycin. Fosfomycin has cidal activity. It has a very good intracellular penetration. Again, its mechanism of action is it inhibits the cell wall synthesis inhibition. It also has antibiofilm activity, and it has been found to have synergy with daptomycin and beta-lactams. It should never be used as a single drug because there are higher chances of acquiring resistance to fosfomycin when used as a monotherapy. Now, there are certain next generation antibiotics which can be used for Enterococcus faecalis, and that includes levonatifloxacin. I have used it in a couple of patients, and especially recently we have a patient with vertebral osteomyelitis who has developed E. faecalis discitis, and initially we had started her on ampicillin gentamicin, but that was to be given almost 6 times a day. So hence we subsequently have de-escalated or down to levonatifloxacin, which was given IV initially, and now she is on oral therapy twice daily. The other important is tedizolid, which also has anti-enterococcal activity and can be used for skin and soft tissue infections. So in this patient with Enterococcus faecalis, vancomycin, although it was susceptible, but we must always, whenever there is Enterococcus faecalis, look at the benzyl penicillin susceptibility, and if it is sensitive or susceptible, also look at the high level gentamicin susceptible. So the drug of choice is benzyl penicillin or ampicillin with gentamicin. Since ampicillin was not available at that point, we initiated the patient on ampicillin with gentamicin, and the patient improved, started improving. Now here, meropenem was discontinued because meropenem has no Enterococcus activity. We have blood culture positive with Enterococcus faecalis. And vancogenta, again, vancomycin is a treatment option for strains which are resistant to benzyl penicillin. That is when there is alteration in the penicillin binding protein 5. However, this particular combination is going to be static, and also both vanc and genta will have nephrotoxicity. As there is no gram-negative infection which has been isolated, the gram-positive, there is no need to escalate to polymyxin B or ceftazidime avibactam. So what we did in this patient was started the patient, ideally it should be ampigenta, but since it was not available, ampicillin with gentamicin was initiated. So as we can see, once this combination therapy of ampicillin with gentamicin was initiated, the patient had a very good clinical response, and there was also a decline in the WBC. Now, all are true except continue Ampicillin gentamicin for 14 days, repeat the blood cultures after 3 days, perform a transesophageal echocardiography, or listen to the patient relatives. So all are true that we must perform a repeat blood culture after 3 days to check for clearance of bacteremia. We should also perform a transesophageal echocardiography, and we must always listen to the patients or the patient's relatives, because it is this which tells us the diagnosis. So the false statement is continue ampicillin gentamicin for 14 days, because once we listened to the patient, we had the diagnosis. And this is based on this very famous quote from Sir William Osler that listen to your patient, he is telling you the diagnosis. And when we took the history as an infectious diseases, this is our skill. So the patient had a history of transverse myelitis. He had a neurogenic bladder. He was on steroids, had constipation, then developed fever for almost 20 days. And then he developed a stroke. So there was a suspicion of infective endocarditis in this patient. And when we requested for a transesophageal echocardiography again, remember the 2D echo was normal, but still insisted on a TEE, and that resulted in the kissing vegetations at the mitral valves. This was a case of infective endocarditis with Enterococcus fecalis. It's very important that an infectious diseases consultation is sought early, because that helps in taking a detailed history taking, and we also can help in interpretation of the reports. It's not just that there is a blood culture which is positive, but why is the blood culture positive? And if there is Enterococcus fecalis in the blood, is there any complication which can happen? So a history taking, and specifically a detailed history taking, can in fact take 30 minutes to 1 hour. So this can be saved. So this time of the ICU team can be saved when an infectious diseases is involved. In fact, infectious diseases intervention has shown to improve outcomes for patients with severe infections, including septic shock, arthritis, Lyme-related infections, bacteremia, endocarditis, bone infection, prosthetic joint infections, and it has shown to decrease the overall index stay, shorter ICU stay, lower the healthcare cost, as well as reduce the or the repeat hospitalizations. So in this patient, he has got Enterococcus fecalis bacteremia with endocarditis. On Ampicillin with gentamicin, the fever had resolved, that there was a decline in the WBC count. He was extubated. As we can see now, he's on tracheostomy. Then during the rounds, we found that there was not a progressive decline in the WBC. In fact, it had gone up again. And this patient had a little cough. So there was a suspicion of VAP. Now, when there's a suspicion of VAP, the possible etiologies can be a CRE, Acinetobacter baumannii, Pseudomonas, and then MRSA. But in that order, it's CRE, Acinetobacter baumannii are the most likely ones, and from center to center, this etiology will vary. So to confirm the suspicion of VAP, a CT scan was done, which showed that there is a collapse consolidation, as we can see here. After sending the samples, the preferred empirical antibiotic in this patient would be Ampigenta with polymyxin B. Remember, this patient now has a Enterococcus endocarditis and with a superadded gram-negative infection, which is likely to be carbapenem resistant. So addition of poly B. But if polymyxin B and gentamicin is given together, that will result in nephrotoxicity. So can we replace gentamicin and switch to daptomycin? So should we give daptomycin with polymyxin B and add fosomycin, which will result in activity against the gram-negative as well as against the enterococci? Give ampicillin with ceftriaxone and continue polymyxin B and fosomycin. This is because if we don't want to give daptomycin, then can we give another agent which can have no nephrotoxicity and continue with poly B and fosfomycin, or avoid fosfomycin completely and choose ceftazidime avibactam with aztreonam for covering the carbapenem resistant GNB if you're not really suspecting Acinetobacter, but there is a high incidence of CR Klebsiella pneumoniae in the ICU, or cut down completely ceftazidime and give aztreonam avibactam and continue with ampicillin gentamicin. So let's discuss this. Can we switch from ampicillin with gentamicin to daptomycin? Now, daptomycin is a treatment option for enterococci, especially the VR enterococci. However, daptomycin for a left-sided endocarditis, the dose is very high, is 10 milligrams per kg, which will result in additional cost. And more importantly, in this patient who has got a stroke, there is also a limited CNS penetration of daptomycin. So that is, a drug which has to be used with caution in a patient with endocarditis with stroke. Another possibility is to use fosfomycin. Fosfomycin will have activity against, usually will have activity against Enterococcus faecalis, and will also have probable activity against the CR Enterobacteriaceae, especially Klebsiella pneumoniae, but will not cover the Acinetobacter. However, if you're giving poly B as well as fosfomycin together, it will result in side effects, and cost is going to be a major problem. So, can we use a drug which is not nephrotoxic or a combination which is not nephrotoxic? So, ampicillin with ceftriaxone can be used for patients where who are having a higher risk of nephrotoxicity or a HLAR, and give poly B and fosfomycin for the resistant gram-negative. And in an ICU where Acinetobacter is not really so much of a concern, but there is a higher risk of carbapenem resistant Klebsiella pneumoniae, then we can choose the option of not giving poly B, but choosing ceftazidime avibactam with aztreonam. But in this particular molecule, there is a problem of beta-lactam overload, and of course the PKPD is inferior to the aztreonam avibactam. So aztreonam avibactam will be a preferred combination for treating the NDM Klebsiella pneumoniae for better pharmacokinetic pharmacodynamic profile. It has definitely lesser toxicity, and also so in this patient we decided to choose aztreonam avibactam and continued with ampicillin gentamicin for the Enterococcus faecalis endocarditis. And as per our clinical suspicion in this patient who had VAP, the LRTI bioviral panel was performed, which detected Klebsiella pneumoniae, as we can see here, and this was NDM with OXA48. The tracheal as well as the blood cultures grew Klebsiella pneumoniae, and this was intermediate to colistin and susceptible to fosfomycin. So in patients, in this particular patient, we use aztreonam avibactam, but suppose aztreonam avibactam was not available, phospho with poly B would have been the other possible combination. But that combination will definitely have higher toxicity, more cost. So that is why ATM AVI will be the more preferable treatment option for the NDM Klebsiella pneumoniae. Now, as we can subsequently, the ATM AVI was started and the patient started having improvement. However, there were also the course was a little tempestuous. This patient had developed drug fever, C. difficile, as well as candidemia. And then by giving the appropriate therapy, we luckily managed all of this, and the patient was discharged. You can see that there was also a decline in the CRP. So there are certain basic principles for choosing the antibiotic therapy, and that would depend upon the site of infection. That is, for sites like endocarditis, meningitis, CVC related, infections, acidal therapy is always preferred. In immunocompromised patients with enterococcal bacteremia, acidal therapy is also preferred. For bone infections, we can use teicoplanin because teicoplanin has a better bone penetration as compared to vancomycin. But probably choosing oral antibiotic option will always be also a concern. The choice of antibiotic will also depend upon the PKPD of the antibiotics, whether the antibiotic is cidal or a static and is able to achieve a good concentration at the site of infection. Like Ampicillin achieves 600 times more concentration into the urine. So if it's a UTI with Enterococcus fecalis or even Faecium, but if the drug like Ampicillin is susceptible, we can choose Ampicillin alone. And if it is cystitis with Enterococcus fecalis, nitrofurantoin can be used as well rather than using Ampicillin IV. For intra-abdominal infections, tigecycline, minocycline are good options as well. We have to also consider the toxicity and the side effects of the antibiotic. Choose antibiotics which are not nephrotoxic in patients, especially who are at a higher risk of nephrotoxicity. So avoid Genta, Vancomycin in patients who are at higher risk for nephrotoxicity. Again, choose drugs like teicoplanin, daptomycin, uh, based on the need. But when we are starting, then we must monitor the side effects related to daptomycin. So it can also be a pneumonia in the lung, and of course CPK-MB every 7 days has to be performed. Linezolid, once it is initiated, should be sought out for the CBC should be done, anemia, thrombocytopenia, and if it is given for a long duration, like more than 28 days, it can result in neuropathy and optic neuritis, which can be irreversible. So whenever a drug is chosen, the side effects also have to be kept in mind, and it is better that someone who's an expert in dealing with the antibiotics has a regular follow-up of the patient so that complications or side effects can be picked up ASAP. Fosfomycin again is a good can be used for treating enterococcus infections based on the site, especially if there are no treatment options like for endocarditis or for bone infections, because it's a very small molecule and has a good penetration. In drugs, in patients where there is allergy to beta-lactams, vancomycin, linezolid, daptomycin, minocycline, levonarifloxacin, tedizolid are the other treatment options. And it's always important to choose drugs which have got lesser collateral damage, like for cystitis, nitrofurantoin will be preferred over fosfomycin. And if there is a source which is responsible for the Enterococcus bacteremia, like an abscess or a wound, a line, then that has to be taken care of. This slide describes how we can use and why we can use ampicillin and ceftriaxone for treating enterococcus. Although ceftriaxone as such has no activity for enterococcus, ceftriaxone binds to the non-essential penicillin binding proteins 2 and 3, whereas ampicillin binds to the essential penicillin binding proteins 4 and 5. And when this combination of ampicillin and ceftriaxone is used together, it is cidal. So this can be used for patients who have a high risk of nephrotoxicity or have a high level aminoglycoside resistance. And in fact, we had presented our experience way back in IDSA of treating patients with enterococcus with this combination therapy of ampicillin with ceftriaxone. Um, and the only thing which we need to watch out for is the drug fever, which can happen because we're giving 2 beta lactams, and if it is used for a longer duration of 4 to 6 weeks, then a new onset fever on ampicillin, ceftriaxone, drug fever has to be kept in mind. And this is one of the important articles related to how do I manage a patient with enterococcal bacteremia. And in fact, this is one of the recent overviews of enterococcal bacteremia with potential treatment options, where this was published from one of the centers in Jaipur, where they showed that almost the rates of VRE is close to 85%. So VRE is increasingly become a difficult treatment option. This is a summary of recommendations of antibiotic treatment for Enterococcal bacteremia and endocarditis, and for uncomplicated, if it is susceptible, then ampicillin, whereas for endocarditis, ampi with genta or ampicillin with ceftriaxone. And for vancomycin susceptible, we can, if it is resistant to the ampicillin, for vancomycin susceptible, vancomycin, daptomycin, linezolid, and based on the site of infection like intraabdominal, tigecycline, minocycline, UTI, fosfomycin can also be used. It's important that an infectious diseases consultation is involved early, as the role of infectious diseases consultation has emerged for the care of enterococcal bacteremia, and in fact, it was associated with a significant lower 30-day mortality rates. We can also reflect the importance of infectious diseases consultation for enterococcal bacteremia. In this particular poster, it is reflected, which was presented in CIDSCon almost a decade back, where this Enterococcus was the second most common cause of infective endocarditis. And of all the IE cases, before the infectious diseases consultation, broad-spectrum antibiotics like meropenem as well as vancomycin were chosen. However, after the infectious diseases consultation, the narrow-spectrum antibiotics like the ampicillin with gentamicin or ampicillin with ceftriaxone were used for treating the complex infection of the heart. And in fact, a change of antibiotic was done in 25 out of the 32 patients. And this is definitely an example of the low-hanging fruit for antimicrobial stewardship. We have to treat infections sometimes even beyond the guidelines, and the therapy has to be individualized. This was one of the difficult cases of Enterococcus infective endocarditis, who had allergy to ampicillin, had nephrotoxicity, and AKI related to gentamicin. And this patient was put on daptomycin but had developed daptomycin lung toxicity, so he had infiltrates into the chest. And in fact, because of this, the surgery also was postponed. But we luckily managed this patient successfully with surgery and with fosfomycin combination therapy. So it's important that in this era of antimicrobial resistance, we also suspect the right organism early, so that we can do or perform the right test and then choose our antibiotics early for the early recovery of the patient. And this bundle approach is the ray of hope in this antimicrobial in this era of antimicrobial resistance. And we welcome you all to CIDSCon 2026. Please block your dates. We would be happy to host you in Ahmedabad from 20th to 23rd August. Thank you so much.